Okay, so today I would like to welcome Achyut Rokam and Hargun Kaur from 60 Decibels, who will be presenting today, as well as Teo Ergbobo from Oxmed and formerly of MSD for Mothers. So please, please go ahead and you can start sharing your screen. Welcome.
Thanks, Laura. It's lovely to meet all of you. So I'm going to set the stage for just a minute, after which Hargun, my colleague, will take over to present some of our insights from the study. And I want to say right off the bat, right? Neither are we at 60 decibels experts at reproductive health, nor are we experts at the local contexts in Kenya and Nigeria where we did the study. But we are experts at telling a story through data. And that's really why we partnered with MSD for Mothers and with Temiteo late last year. Theo came to us with really interesting hypotheses and a research study, an idea for a research study to listen to women, listen to pregnant women and mothers around their experience with accessing maternal health commodities. Now, these commodities could be essential drugs needed during childbirth, or could be any medical supplies that nurses or facilities might need during childbirth and during the operation of delivery. Now, there were a lot of studies around the access to such maternal health commodities, but very few studies that actually came from speaking to women themselves. Most studies and most insights in the public domain came from the supply side angle. And this was perhaps one of the first or one of the few times that we were running such a large scale population level study with the women themselves. So the course of 3 to 4 months late last year, we spoke to over 2,000 women in Kenya and Nigeria in selected states and counties to build on earlier insights and studies. And the meat of this presentation is going to be insights from that study. Our main objectives were to really understand whether women were actually getting access to some of the medical supplies and drugs and commodities that they were promised by existing policies in both these countries. If these maternal health commodities were quality assured, if women were even aware of how to assess such quality, if they were able to afford these medicines, and also just understand their general experience with access to maternal health care in general. So that's the general context. I'm going to hand it over to Hargun, who's going to walk us through the insights itself, which is going to take perhaps 10 minutes or so. And then Temiteo will sort of build upon this context that I've shared. He's really the expert in reproductive health here, of course, apart from all of you as well. And at the end of this, we can, of course, circle back to question and answers. Okay, over to you, Hargun.
Thanks, Achyut. Hi, everyone. So I think I'll dive straight in. But basically, the aim today is in this presentation, we're going to focus on 3 key insights that we learned from speaking to recent mothers about their experience acquiring these maternal health medicines. And although Achyut's already set some context, but I'll also briefly recap the methodology that we used, just recap how we did data collection, and then we dive straight into the insights. Starting off, basically, our overall goal was to speak to recent mothers, and by recent, we meant anybody who's given birth in the last 12 months, as of the data collection period that was November, December, throughout November, December last year. So our goal was to speak to recent mothers and understand their experience acquiring these maternal health commodities required during childbirth. And this being a key goal, we can break them down into 4 objectives of the study, which was the first one being are women provided with these maternal health commodities that are quality assured? And as Achyut also mentioned, when we say essential commodities, what we mean is prescription-based medicines such as eutrotronics, analgesics, antibiotics, and then medical supplies such as gloves, alcohol swabs, or saline drips. And then the second key objective was around information, where we wanted to understand if women are equipped with the necessary information to acquire these commodities. And we did this through a couple of metrics that we had in the study, where we tried to understand information that women have in particular aspects related to maternal health commodities. This could be, firstly, if they receive prescription, or if they also had information about storage, how to store medicines, how to use these medicines, and we can see that further through the presentation as well. Then the third one is around purchasing. So where do women actually acquire these commodities? And are the pharmacies that they acquire these commodities from conveniently located and well-equipped, as well as how much of a burden this expense is to purchase commodities? Then the fourth one is around challenges, where we try to explore if women are facing any challenges acquiring these maternal health commodities. And then to answer all of these questions, that these 4 key objectives that we want to try to understand, we designed a study to speak to women themselves, specifically who had given birth again in the last 12 months. And we chose 4 counties across both Kenya and Nigeria, 4 counties in counties in Kenya and 6 states in Nigeria, where we conducted the study. And overall, we spoke to 2,000 women. So across these 4 counties and 6 states, we had a sample of 200 each. And why we chose these particular counties and states was because based on previously we'd spoken to and went into and understood that there were studies that were already existing in these places, and we wanted to add to that literature. And these studies were already existing, were conducted by organizations like White Ribbon Alliance in Kenya and then Nigeria Health Watch. So we spoke to about 200 women across these counties and states, and all these surveys we conducted in person. And how we would do this was that our enumerators would approach areas such as daycare centers or community health centers, which were likely to be visited by these pregnant or recent mothers. And then all the subsequent interviews we'd make through the referrals we'd get from these mothers. All right, that was mainly a recap of the methodology that we used. And now into the insights. We have 3 key insights, and as Akshat said, we sort of have disaggregated them into 3 A's, which is access, awareness, and affordability. So starting with access, when it comes to it, we saw that overall the access is low across multiple dimensions, such as access to maternal health commodities at the birthing facility is low, and then pharmacies are not really conveniently stocked or not conveniently located, and there's not enough stock for these necessary medicines that women are asked to purchase. And so from the chart at the left, you can see that overall, 73% of women in Kenya and 94% in Nigeria say that they were asked to purchase these maternal health commodities. Actually, before we dive into the insights, I'd also like to sort of highlight here that while all of this evidence for Kenya and Nigeria is presented together, we sort of acknowledge that, of course, policies are different in both of these countries and there are different historical contexts. So all of these insights, while they're presented together, are not really meant for direct comparison, but just sort of so that we can have all the numbers in one place. So both of these countries, majority of the women were asked to purchase medicines themselves. And then when it comes to particular metrics related to access, we saw that 20 to 25% women in both the countries said that pharmacies are far, or that they need to visit more than one pharmacy to purchase the commodities, or that these commodities were not really available when they needed them. Sort of our hypothesis here is that there's unequal access to transportation, and that social support could be sort of a barrier to women, which is preventing them from accessing these commodities. And then when it comes to social support, we saw that approximately 70% women in Kenya and 38% in Nigeria say that they had to procure these medicines themselves without the support of a friend or family member. Now, since there's a lot of responsibility of women to procure these commodities on their own, rather than the health facilities. We wanted to sort of also dive into if women really have that sort of information to purchase these commodities. And that's where the second insight that we had comes in, which is around awareness, where we see that most women do receive prescriptions or some sort of basic information or instructions, but still a quarter of women are unaware of how to assess the quality of these medicines or certain other informations like how to store them or what are the particular potential side effects that these medicines might have. And so, firstly, when we talk about prescription, right, we saw that majority of the women, like the numbers are good here, 9 in 10 women in both Kenya and Nigeria received a prescription. But when it comes to specifics of further information shared, we saw that only 1 in 4 or a quarter said that they were given instructions on things such as quality or storage or side effects of these medicines. Then the third insight that we have is around affordability. And we saw that we wanted to sort of see here that how are women financing these commodities, and then how do they perceive affordability of these medicines, right? And so when it comes to financing, we saw that both across Kenya and Nigeria, about 70% of women primarily depend on savings to purchase commodities, or 20% say that they have been borrowing from friends or family to pay for these commodities. Less than 10% across both the countries are covered by insurance to purchase commodities. And when we ask them about how they perceive how affordable these medicines are, we see that a third of them across both the countries say that they find the medicines expensive. And so based on all of these three things, and the goal of the study was to understand the life experiences of women accessing maternal health commodities, we sort of wanted to generate evidence that could be useful for government or policy decisions. And then based on all of the study and the data that we had, we have 4 key recommendations. And just quickly diving into those as well. The first one is around strengthening availability of commodities within the public health facilities. And what we mean is that we need to ensure sort of the availability of essential commodities within the public health facilities. How we can do that is through strengthening supply chains and then ensuring that there's enough financial flow so that we can replenish stock at public health facilities. The second one is around reducing financial barriers for maternal health care. And we see that there's a need for more transparency from a health facility in what sort of commodities are women expected to buy. And then we also need to expand insurance schemes that could help ease the burden on women and reduce or lessen their reliance on their personal savings to purchase commodities. And the third one is around strengthening public and private collaboration. As we had seen earlier also, we saw that majority of the women are asked to purchase commodities, and then when they're purchasing, they prefer to acquire these medicines from private pharmacies as compared to public facilities. And so if we can involve private pharmacies through a multi-stakeholder approach, that could help improve stock management and also strengthen supply chains. And when I say multi-stakeholder, what I mean is the involvement of NGOs or community organizations that could help improve awareness of insurance schemes and also help improve utilization of such schemes. The fourth one is a recommendation around what other areas or additional areas where we can explore so that we can strengthen the insights or add to the insights that we already have through this study and whatever other studies that exist in the space. And so firstly, we think that similar studies or similar research or listening exercises with additional stakeholders could generate evidence that is useful for policymakers. And when I say additional stakeholders, these could be pharmacy owners or facility administrators, healthcare workers, which can help us look into or sort of uncover additional gaps that exist in the policy space here. And then The second and more obvious thing is that we can expand the research into more areas. So covering more counties and more states across Kenya and Nigeria could help us firstly validate the findings that we already have, or see if there's any additional, or if the data is different across these other counties. But yes, that's the end of the presentation from 60 Decibels. I'd sort of like to thank firstly the Rabin Martin team and the MSD team for support throughout the study. This was a very long project, and we're glad that we could sort of uncover all of these interesting insights. I'll hand it over to Teo, and also further, if there's any questions, open the floor for that as well. Thank you so much.
Excellent. Thank you so much for that presentation. Super proud that basically this work is completed, and also the findings are published. I'll just share my screen if this works, hopefully. Is my screen? Excellent. So my name is Tayo Erububu. I'm the Global Head for Corporate and Public Affairs at AXMED. And as Laura said, I was formerly at MSD, where I led multilateral organization engagement and global advocacy for the MSD for Mothers initiative. And under that, I had the privilege to be able to commission this work in collaboration with 60 Decibels, and with support from the Rabin Martin team, and also had great support from my MSD colleagues as well on this journey. So I want to thank them all, and also thank them for inviting me back to be able to comment on this. Clearly, I must have done something right. But on a personal note, I'm also pleased that basically this actually very much links to the work I do on a day-to-day basis now, and has been a long passion of mine in terms of how do we actually elevate the perspective of women in care, and also how do we ensure that access to health products and commodities are actually prioritized, which may sound an odd thing, but I've been in this space for over 20 plus years. And we tend to have a narrow perspective on the discussions around health products and medicines, why we have them, why we don't have them, and typically is around price, and typically is around supply chains and all the bits around it, which is far more complex. I feel that basically has often been left off the table. But this, I think, provides some insights into some of this, as well as some of the former work that Hakan mentioned in her presentation. So I'm going to do just 3 simple things. I want to provide some further reflections on the findings, touch on why I think some of this matters, and some of the suggestions around what we can do about it. Fairly high level, but hopefully we'll be able to have some discussions around this, and in line with the objectives of the study itself is to really help facilitate further discussions. And there are actually some concrete things that we can do in terms of implementation already. I would hope we can actually discuss some of that as well. So in terms of some quick reflections, as the team have already said, over 70% of women were asked to purchase essential products, and 1 in 3 of them found this to be expensive. And also they're paying out of pocket for these. This speaks to issues around supply and access, which are fundamental to this discussion, and I'll explain later in terms of why there are micro dimensions to this and also macro dimensions to this. And then in terms of some of the other key findings that jumped out at me is looking at Kenya and Nigeria, that women were actually being asked to purchase this themselves. And majority of them were not told about issues around quality, storage, side effects, etc., which speaks to a lot too about to the regulations that are in place, and some of the processes that are in place, and the implementation of some of those regulations and how they are impacting women's behavior. So those are sort of like, some quick reflections around that, but I would like to touch on what this is actually telling us. As the team said earlier on, this builds on a body of different work that are already in place. If we look at the What Women Want campaign by White Ribbon Alliance, I think we can clearly see that this aligns with some of the findings from this survey, which was back in 2019, a survey of 1.2 million women across the globe, where over 36% of them said access to supplies and services was their number one priority of all the women, the people that are surveyed. The others were included water and sanitation, dignified care. And I think that basically shows how important this is for people that are accessing these services. If you worked in this space for any length of time or come from this region, your experience, if you go into a public health facility, in terms of being able to get access to the essential commodities you require, is one that basically is tangible. You don't know whether you're going to get these products or not. And that informs some of these priorities. And I've worked in both Kenya and Nigeria. And again, if you walk into any facility, you know that basically this is a regular challenge for a lot of folks. And I think the work that Nigeria Health Watch also did a few years back also indicates how this is actually translating into some behavior. If you look at where women are giving birth and some of the issues that they talk about in terms of visiting facilities, some of the indications that actually not having access to the commodities that they need, the kind of services that they need, also means that a large proportion of women are actually accessing the service away from health institutions. That is a significant challenge, because we obviously know that basically if women give birth in facilities, the chances of having a better experience in terms of reduction in maternal mortality and also reduction in morbidity is better. But clearly, I mean, the experience currently in a lot of settings is not good. And then if we look at what the midwives who are delivering care in a lot of these settings are also saying, apart from pay, the number one issue that they faced, and actually one of the drivers around not being able to continue in service, has been around access to equipment, supplies, and that enable them to be able to actually provide the service that women require. All in all, I think what this is saying is that this issue really matters, and this issue is having an implication on how people are accessing services and delivering services. And then understanding, looking at the work that, again, White Ribbon Alliance did in Kenya, one of the perspective that has been missing, which the study begins to nudge us towards, is around the understanding of quality from a women's and girls' perspective versus what we've traditionally done, which has been looking at it from a healthcare or a government perspective, healthcare provider or a government perspective, and thinking about how we believe people should be accessing these services, or what their experience should be and what they should be prioritizing, not what they're actually living through. So I think this builds on this evidence around what women want and what their experience currently is, and the disconnect between what our aspirations may be and what they're actually feeling on the ground. So what can we actually do about some of this? I mentioned earlier on, there are some macro issues and some micro issues. On the regulation front, I mean, I remember discussing this with the team, and they were like, "Oh, what does this mean in terms of regulations and policies? And we need new things." And so the issue is actually not so much about the fact that we need major changes in terms of regulations, but actually some nudges in the right direction. But fundamentally, we need to actually implement what is already in place. So, for example, in terms of affordability, if you go to most counties in Kenya, or you go to a state in Nigeria, and actually government policy, from a federal point of view, maternal health is meant to be free. But what does free actually mean if you don't actually have the capacity, or you haven't invested in those services to be free at the point of access? And you haven't got systems in place to ensure that that is implemented. So that is fundamentally a challenge around implementation, versus the fact that basically the policies or the ambition aren't necessarily there. And then what we can also sort of speak to is some of the macro issues, which goes to the fact that basically when we look at across LMICs, the cost of medicines that governments with the right intention are wanting to procure is a lot higher than in a lot of developed settings. Typically, we pay significantly more in LMICs for supplies of medicines. And some of these issues are around the financing of procurement of these medicines, where either government doesn't have enough funds to procure, or typically the distributors in the middle have to often finance the procurement of these medicines at quite high interest rates, and also lack of access to finances generally in terms of procurement of these medicines. And then the issue around quality. Generally speaking, we've done some further studies around this when I was at MSD, through my colleague who's probably online, Jeff, in collaboration with USP, where we supported a study in Nigeria looking at the quality of ultrasonics, where over 80% of the ultrasonics were seen to be either fake, falsified, or substandard. So quality is another major issue, which actually goes to one of the sort of like the macro interventions that we could make, which is around how do RFPs actually often go out when states, for example, are procuring these medicines. In both countries, Nigeria and Kenya, health is devolved from federal to the state level. But when we look at procurement and the procurement standards and approaches, seldom are quality markers put in place in terms of what products are being are required, and who can actually sort of respond to some of these procurement tenders. That is something that can easily be changed in terms of what are you demanding. There's a lot that that the state's leadership, or at the federal level, or whoever else procuring, can actually demand in terms of the quality of the products that they're procuring. But again, as I said before, seldom is actually some of this baked into a lot of the RFP. People typically just say, we require X. Not we require X at this standard, at this quality, ensuring that basically their quality assured. And then to this macro issue more broadly, is a question of how do we actually reduce the overall cost of medicines at a quality level that governments and other procurers are making. And that leans into my current role, actually, but this wasn't planned and I didn't set this up before I transitioned out of MSD. But one of the things that is really important is to be able to create a demand in these settings where the cost of these medicines, because of the aggregated demand, the scale of the demand in these settings, can drive down the prices of these commodities. Like I said before, the cost in a lot of LMICs where the needs are greatest is a lot higher than in places that arguably can afford it. And the only way we're going to like change some of the dynamic is actually creating a marketplace where we have an aggregated demand that we can use to have those conversations with manufacturers and suppliers, where we can have a regular supply of commodities at a cost-effective price ultimately. And that's what we do at AxeMed, and what I spend my day-to-day working on with the team. And it's a wider issue, which I think unless we fundamentally address, at least on the supply and access side, we don't begin to sort of get to that. Even with the best intention and implementation on the ground, if the cost of the medicines are high, there's only so much that can be done. Having said all that, though, I think there is a lot of space in ensuring that these experiences of women at facility are better collated, are better presented, and the question is who's looking at it and what is it informing in terms of decision making on a regular basis. That is often missing, but we've seen that this can be really impactful. Again, if you look back to the What Women Want campaign, what was saw from the campaign was that where the data around women's needs were presented to decision makers, this really concretely nudged behavior and investments, including improved budgeting and release of budgets for commodities. So I think another micro intervention we can make is definitely how we collect this data more routinely and how we ensure that this is actually presented to decision makers. So I'll stop there. And again, thank you very much for the opportunity to be able to contribute. And we're open for questions. Back to you, Laura.
Thank you for the presentations and all the information. Do we have any questions from anyone? You can write it in the chat or come off mute.
Thank you, Laura. I had a question. Have these results been published? Where can we find them? How can we disseminate these results, especially among our members in Kenya and Nigeria?
Yeah, hi, Milka. So these results commissioned by MSD for Mothers has also been published on their websites. In fact, I'm going to share those links on this chat, and that's where you can access it.
Other questions?
On silence.
It's a quiet group today.
Maybe I can ask a question, Laura. So thank you for the presentation. When you presented these results with the national stakeholders, what were the initial reactions you got from them?
Ashkan, do you want to go, or should I?
We haven't been personally involved in presenting to any of the government officials yet. So yeah, maybe Teo, if you have experience with that. I don't know if you have specifically to this report, but perhaps other reports in general.
So yeah, and I don't want to speak for the rest of Mother's team, but I don't believe basically this has been presented formally to both governments yet, from those country and local stakeholders or officials. But in my a formal conversation, like I said before, in my new role within AXMED. What I have been doing is actually sort of like, trying to highlight some of these findings in my bilaterals to different folks from both countries. Recently, I was in Nairobi, where I was speaking to the special advisor to the president on women affairs, and a lot of our conversation actually centered around lack of access to Commodities, and I highlighted this. In fairness, there wasn't so much of a surprise by them, disappointment. And I think one of the major takeaway from them is about implementation. How do they continue to work on the implementation of the policies that they already have in place? One of the things they also spoke to is around the supply and access parameters. There's some local changes happening in Kenya related to how medicines are being procured, which will come on stream very shortly, which they hope will improve the access and supply elements of things. I'll be in Nigeria next week. I hope again we'll be able to speak to other stakeholders related to the findings. But again, from some of the bilateral conversations I've had with different stakeholders, again, not a surprise, because again, if you live in these settings, these experiences is something that you know. But seeing it on paper, I think makes a difference to folks. But formally, I think one of our next steps is actually have a formal conversations and discussion with government and other stakeholders in country. Over.
Yes, Comfort, go ahead.
Hello, everyone. Thank you very much for this presentation. And like what has been mentioned, that the findings, even for Nigeria, will not be surprising. Because currently in Nigeria, the government seems to be taking a different route and initiating a lot of programs and initiative to crash maternal mortality and morbidity. However, it's good also that we have this, which is timely, because part of the drive to crash maternal mortality and morbidity, at the center of it will be the availability of the commodities. So I think while Temitayo is mentioning that there will be discussions, I think it's good to buttress the fact that the availability of commodities is very, very essential and key to being able to crash maternal mortality and morbidity. Seeing that most women pay out of pocket, and then you find in some states again, there is the drive for free maternal services in health facilities. However, some commodities again that are required to take care of these women during their pregnancies and post-pregnancies are also expensive and sold in the health facility. So how can we ensure that these are accessible, even if they are going to be sold in the health facilities? How can they be affordable to these women? And not just about the availability and affordability, also we need to also look at getting these commodities to the community level. So now engaging the private sector, because that's another part of the system that has been hugely sidelined. And you find that most of these women, pregnant, post-pregnancy, and even during caring for their children, visit private sector. However, the private sector is not involved in this discussion. So how can we also engage the private sectors and also the communities in this discussion, so that it's now a holistic discussion, not just focusing on the public sector alone? Thank you.
Comfort, I couldn't agree more. Yes, yes, yes. Certainly, on the access point, totally agree with you that despite the fact that the ambition is there to ensure that we crash maternal mortality in Nigeria, there is a disconnect between that ambition and the reality on the ground, and the fact that basically access to commodities is a fundamental part of that. And how do we reduce both the cost but also improve the supply into the front line to the facility across all kind of institutions in the country. And I love your point around the fact that basically we need all stakeholders at the table, because when you look at the data, majority of, or at least half of women are delivering at private facilities, but yet they're not integrated, as you said, in a lot of the discussions. How do you ensure that they have the commodities that they need at an affordable price, which goes to some of those macro issues. And I know at a strategic level, the government are involved in at the federal level, involved in ways in which they want to try and help reduce some of that. Some of that is then responsibility of the PVAC group in trying to help consolidate some of the demands for health commodities in the country, to help to drive down the cost at which these commodities are being procured. We're actually, only just yesterday, we're having conversations with them in terms of how, from an AXMED point of view, we can help in that process, in aggregating demand beyond Nigeria to further help reduce the cost of those commodities. But even when they get into country, the question is, how do we get it to the facility, and what cost are women accessing those commodities? Some of that's around supply, and who are the partners in country that can help to actually get those products to where they're needed and in an efficient manner. Because very often, actually, some of these commodities sit in warehouses in different location, but the logistics aren't there in a regular, consistent manner to ensure that they can get to where they're actually required, which would then mean that basically women have access to them. But also, if there's a regular supply of them, the cost can actually also be reduced across the supply chain. So all these elements are really important. But I love your point in terms of being able to pull in the right kind of expertise across the ecosystem to be able to address the different gaps, because there are different challenges across the overall supply chain. And ultimately, it's about implementation and prioritization, because as you said, the policy and the ambition is there. But if we don't have some of these processes in place, then we're going to be challenged.
Any other comments or questions for our presenters?
I also have perhaps a request if the group is not saying anything, in terms of, just trying to find out ways in which, from your work, those are online, what your experiences have been, and ways in which we can actually sort of help to pull some of those findings into, from based on your work, into the overall engagement around access to maternal health products. I strongly believe that the more voices we have at the table, and the more insights we can get from different stakeholders, the stronger our case is, and the bigger the momentum that we get. So would love to hear from folks based on their work, if they have any studies, insights from their work that can actually contribute to the overall understanding of experiences of women accessing services across either Nigeria or Kenya, or certainly beyond that as well.
Anyone willing to speak up? Or maybe we could follow up after the webinar to share out relevant work that's happening. I see a few people are dropping off. I think it might be time to switch to other meetings, but thank you very much to Tayo, Nechut, and Hargun. It was very educational. And thank you for sharing all the links in the chat for the publications and where we can find all of the details of the study. Thank you again to everyone for joining. and we will be sharing the recording soon.
Thank you very much.
All right. Take care.
Thanks,
Have a
everyone.
good rest of your day.
Bye.
Bye.
Bye.